At Children's, we use a combination of tools and tests to determine if a patient has a concussion.
We assess the patient based on the Glasgow Coma score. We get a score from 3 being the lowest to 15 being the highest. Those children that have severe head injuries are a Glasgow Coma score of 8 or less. Those that have moderate head injuries are between 9 and 12 inclusive. The mild head injuries are 13, 14, and 15 Glasgow Coma scores. There are 3 components. One is verbal, motor, and eye response. The motor response is the most important, and it's given a scale from 1 to 6. 1 being no response, 6 being a motor response that can follow commands. For example, you'd ask that person to raise their left hand, and they'd raise their left hand. That would be a motor score of 6 versus somebody who has no response at all. The verbal response is from 1 to 5. 5 being somebody who's awake, alert, and responsive. 1 being no response, with stages 2, 3, and 4 being degrees in between. The eye response is eyes that are spontaneously open. You walk into that room, the patient's looking around. That would be a 4. That's a highest score you could get for eyes, versus a 1 where the eyes don't open regardless of the stimulation or pain that you give to that patient. We start off by asking them how the injury occurred, was it witnessed or unwitnessed, and did they lose consciousness or not. Please note that loss of consciousness is not mandatory to make the diagnosis of a concussion. In fact, at least 1/3 of patients who sustain a concussion, if not more, do not lose consciousness completely. We ask them if there's any amnesia and what other cognitive signs did they have. Were they dazed? Were they stunned? Were they confused? And all of that is documented on the initial assessment. After we get the initial assessment for the event, we ask 4 specific areas to assess the degree of concussion. These are the physical symptoms, the cognitive symptoms, any emotional problems, and any sleep disorders.
When assessing a concussion patient, knowing the signs are key. Some common symptoms include confusion, nausea, memory loss, sensitivity to light, and fatigue.
Well, we're looking for 2 different things when someone's been head injured. The most serious thing we're worried about is a surgical emergency. Whether or not someone's had an injury that is so devastating that they need to have surgery then and now. That is a different kind of patient than the patient who's had a concussion, who also has a serious injury but requires a different approach. The person who has a surgical emergency needs to have neuroimaging immediately and be evaluated by a neurosurgical subspecialist. The patient who's had a concussion doesn't require either one of those necessarily. And so deciphering the 2 of them is tricky. Depends on your clinical experience and expertise as to whether or not you're going to get that evaluation. And so explaining to the parents that yes, there's been a brain injury and we call it a concussion, and it's not something that you can see on a CAT scan. And in fact, there's no indication for a CAT scan, but there is an indication for important follow-up and rest in a prescribed manner. So making that distinction between the functional head injury, the concussion, versus the surgical head injury is a tricky one for parents to understand sometimes. Our challenge is demarcated based on whether or not they can communicate well verbally. So we look at children under 2 and older 2 a little differently because of those challenges. When you have a patient who's got a very good vocabulary, you can test them. You can test their higher functions well. With adults, you do something called a mini mental status exam to see how well those higher functions work. Unfortunately, we don't have a standardized mini mental status exam for kids because it's hard to standardize those tests for every child. Those things include spelling words like world backwards or counting backwards from 100 by 7s. You can't ask a 4-year-old to do either of those things. So you have to rely on other signs and symptoms, including change from baseline, and asking the parents, do they seem all right to you? Because there's variety in children. So it's a big challenge, and we have to have a good gut feeling about kids, have to have an understanding about what to expect of a head injury, and sometimes when we're not sure, we simply just watch them for a while and make sure they're heading in the right direction.
When you're dealing with concussions, some of the issues that you may have to deal with are sleep, appetite, and mood. Often after a concussion, up to 3/4 of patients can complain about sleep disturbances. And this has to do with either poor sleep, or it can deal with daytime sleepiness, or the ability that they can't fall asleep. So many of the recommendations that we'll have is really to focus a lot on sleep hygiene, trying to remove things that can be stimulatory before bedtime, such as electronics, television, keeping regular bedtimes, and really trying to stay on a very regimented pattern of trying to go to bed and wake up at the same time. Now, in terms of appetite, often children are either too hungry or not hungry at all. As a general rule, we do recommend that you encourage your child to eat, particularly regular meals and at regular intervals. It does not necessarily have to be the same amount that they typically eat, but it is important that we do maintain good nutrition so that they can have enough energy for the brain to heal. Often changes in mood are also associated with concussion. There can be a lot of irritability and mood changes associated with the injury itself. After a concussion, you should monitor for signs and symptoms of anxiety, depression, and mood disorders. If these symptoms persist, you might want to consider referral to a specialist. Younger children may not be able to express their feelings. As a clinician, you should talk with the parents and determine how the patient's behaviors have changed from their baseline and monitor accordingly.
Next, we inquire if there are any risk factors. The risk factors include prior head injuries as well as psychological problems such as ADHD, depression, anxiety, etc.
And it's important to have a list of things that are reassuring to a parent in addition to reassure yourself that you are equipped to handle this. The first thing you have to make sure is there any risk that this child's a victim of abuse? And once you've assured yourself that that's fine, I go through a checklist in my mind. Is this child at risk for a traumatic brain injury that could be worsened because of a pre-existing medical condition such as a bleeding disorder? Could this child be more likely to have an intracranial bleed? Is this child normal neurologically? Do you have a normal mental status? Do you have a normal neurologic exam? If you have those things, it's very unlikely that they have the type of injury that requires a CT scan or an emergency room referral is necessary. Can they tolerate liquids by mouth? And can their pain be controlled with oral medications? If all of those things are in place and I'm reassured by my exam, then I feel like this is an injury that I can treat as an outpatient through my office, through my clinic.
Patients with a normal neurological exam and a normal mental status can be safely observed without the need to refer to an emergency department or brain imaging. Concussion patients should meet the following requirements for safe outpatient observation. They can take liquids by mouth without vomiting. They have no signs of a skull fracture, such as bruising under the eyes, behind the ears, or swelling on the head. There is no suspicion for abuse. Their headache can be controlled with oral medication. They have no medical conditions that increase their risk for more serious traumatic brain injuries, such as bleeding disorders.
Once we have all that information, a diagnosis of concussion is made, and we then make a plan.